diabetes patients and a minority unknown. Of the type 2 diabetes patients, to my surprise, 30% were not on insulin, and they still had a very severe hypoglycemia. The mean glucose when the ambulance crew arrived was 1.8 millimole per liter. So we're talking about a very good going hypoglycemia. And as you can imagine, the third of patients who were not on insulin, the majority were on a sulfonylurea. And then we looked at their mortality. So if you concentrate on the left hand of the slide, this is the type 1 diabetes mortality. There was quite a bit of increase. It doesn't look too bad, but actually the mean age here was 49 years, representing a 14-fold increase in mortality over the general population. So there was an increase in mortality in type 1. When it came to the type 2, I was absolutely shocked because you can see up to 24% of patients were dead within a year. Now, I'm not saying necessarily that hypoglycemia caused the death. All I can say from this study that there was a very strong association between hypoglycemia and mortality in our population. Then we've done another analysis. We thought we'll exclude people above the age of 75 from the analysis because they could be frail, and hypoglycemia could have been just a marker that these guys are not well. And when we've done that, mortality was 14% 1 year following the hypoglycemia, which was identical to mortality in the same cohort of patients in Leeds, type 2 diabetes patients, following myocardial infarction. So in our data, severe hypoglycemia and the mortality, your risk of death is the same as the risk of death following myocardial infarction in type 2 diabetes. And to be honest with you, I did not expect these data, and the data are very consistent. Doesn't matter which year we analyze. So conclusion so far, improving glycemic control measured as HbA1c reduces microvascular complications. I don't think anybody disagrees with that. It reduces long-term, and I stress long-term, macrovascular complications. Tight control of diabetes measured as low HbA1c is not always beneficial. I'm not saying don't lower the HbA1c, but be careful what else you are doing there. And then finally, hypoglycemia is certainly associated with increased mortality. Now I'm going to complicate matters for you a little bit more. I know it's the third talk, but just bear with me, just a slight complication here. So we talked about hyperglycemia being bad, hypoglycemia being bad. There's a third thing that is not very good for you, and that's glucose variability. So this is a study that looked at fasting glucose variability, so only one time point, and it showed that people with low glucose variability have got a very good survival, medium glucose variability survival drop, very high glucose variability survival drops further. So glucose variability is not good for you. There's another study that was published in Diabetes Care not a long time ago, and that looked at glucose variability in relation to mortality and in relation to hospital admission. Looks like a complicated slide, but I'll try to simplify it for you. If you look on the left hand of the slide, what that shows is people with glucose values between 90 to 180 milligram per deciliter. So they've got reasonably good control, 5 to 10 millimole per liter. And then they were divided into low, which is the white column, gray is the medium, and the black is the high variability in glucose. And what you see on the very left is admission to hospital, length of stay, and then you see mortality next to it. And as you can see, the black is always higher than the white. So high glucose variability, you get longer hospital stay, you get more mortality. If you go to the people with high glucose above 180 or more than 10 millimole per liter, that's the average, then those effects are even exaggerated further. So high glucose variability is definitely bad for you. And that brings me to that question, What are the targets? Because people keep talking about targets, and as I said, we are obsessed with HbA1c, and I do not believe that HbA1c on its own is enough. It's very useful, don't get me wrong, but it's not enough. And I propose that we should have this triangle when we are trying to deal with glycemia in diabetes. I would say that the simplified notion that the lowest possible HbA1c is best should be modified to include this triangle approach, whereby we say improve glucose levels, i.e. lower the HbA1c, but make sure that you avoid hypoglycemia and try to limit glucose variability. And this is where this triangle coming from. And I must say, I put up this slide first time last year at the EASD, and I was just thinking that I'm stating the obvious, but it had so much success, this particular slide. People love it for whatever reason, that I've been asked to give all sorts of talk about this particular slide. Challenges. To me, improving glycemic control is one of the most difficult risk factors to control. With the cholesterol, you give people a statin, you lower the cholesterol, it doesn't fluctuate up and down like a yo-yo. Yes, you can get side effects with statin, you can get around that, but generally speaking, it's much, much more stable. We've got problems here. The fluctuation in glucose is due to daily activities. So people have to eat, glucose goes up, do exercise, it can drop. The treatment, of course, you can get the fluctuation in glucose, particularly with insulin therapy. There are problems with frequent glucose testing. There's a cost involved, and there's a major inconvenience to patients because it's not easy to stab your fingers several times a day. There's a pain involved, there are the social issues involved with that as well, and the issue of blood. And then, even if you check the glucose, sometimes it's very difficult to interpret what's going on. You know, the patient can't interpret it, and you don't know what to do with the data. Sometimes the patient can't interpret it, and sometimes the healthcare professional can't interpret it. When it comes to self-monitoring of blood glucose, it's got limitations, very useful, but it's got limitations. We already mentioned pain, blood, scarring of the fingers. There's one patient who I saw the day before yesterday, and we're trying him on a different type of testing, which I'll talk about in a moment, and he shook my hands before leaving, and he told me, "Doctor, you saved my fingers." So it's not the easiest thing when you stab yourself all the time. Cost, it can actually escalate. To get meaningful data to change the treatment safely, you need a lot of readings. And published studies do not take that into account because the cost can escalate. Data interpretation, very time consuming. Majority of patients are unable to implement treatment changes, and infrequent testing is quite frankly useless. I'll give you an example. This is a patient who came to see me a few months ago, and he said, "Doctor, I tested for you 3 times a week." Yes, he tested 3 times a week. It's absolutely useless. There's nothing I can do with the data. Another patient was very proud of himself. He said, "I tested for you every day." Well, very nice, we've got the fasting glucose, but unless I know what the pre-bed glucose is, it's very difficult to make adjustment in the treatment. So you can see infrequent readings are completely useless. That moves us to continuous glucose monitoring. Now that's better, okay? However, devices that we have are relatively large. They require regular replacement, 5 to 7 days. They require constant calibration, so you still have to stab yourself to calibrate the device. And they're always attached. They're very expensive. In the UK, we can't afford them. And the data interpretation can be very problematic as well. So what is needed now? What do I think is needed? We need some affordable devices that provide glucose check accurately and frequently, convenient to patients, socially acceptable, and not painful, help with management decision, help the healthcare professional and the patient make management decisions, and is easily explained to patients. It's well known that if the patient understands what you're trying to do, they're far more willing to do whatever you ask them. So I would call that no ache. So do we have something like that? And actually, we do have now one device in the UK that we've been using in research studies, but also clinically. What is it? So you have a sensor, which is the white bit on the right, which is the size of a coin, is slapped on the arm, stays there for 2 weeks, and records the glucose every 15 minutes. It can store 8 hours of data. You get your meter, you swipe it across this sensor. It tells you the instant glucose levels, but it also tells you the last 8 hours, and those 8 hours get transferred to the meter, and the meter can store up to 3 months of data. So the scan is very, very easy, is very convenient, and guess what? No calibration is required at all. I must confess that initially when we started trialing this device and I was told that no calibration is required, I was very skeptical. I did not believe it's going to work, but actually it does work, and it does work beautifully. And I tried it myself actually. I put the sensor on my arm. Now the other thing this device does, it doesn't only give you a reading, but it tells you the glucose reading using AGP. So let me take you through AGP. When you have continuous glucose monitoring reading, you get all these lines that can be very, very difficult to interpret. So when you construct an AGP, it takes these different readings and construct a median. So the median tells you the 50% of readings above, 50% of readings below. Then it constructs the 25th and the 75th percentile, and the 10th and the 90th percentile. The 10th and the 90th percentile will tell you 80% of the readings that are within that range. So it tells you the median plus the range of the majority of your readings. Because as you know, when it comes to diabetes, we don't sort of look at 1 or 2 readings. We want to see patterns. So you get something like this. So you see the line in the middle is the median, then you've got the range, 25th to 50th percentile, so 50% of the readings there, and the outer range is 80% of your readings are in there. And to make it easier for you, we can do a bit more. If you remember the triangle of diabetes care that I presented before, we can do that as well and have these 3 parameters looked at. And you can have a traffic light system. So low glucose, you can have a traffic light system. If it is red, high risk of hypoglycemia, amber, medium risk, and if it is green, no risk whatsoever. So in this particular patient, you've got no risk of hypoglycemia. All the hypo is in green. Median glucose, you can set the target to whatever you want. The target is set at that line. As you can see, most of the readings are above that line, so median is tracking above the line, but just. That's why you're getting amber. You're not getting red. When it comes to variability, there's more variability than I would like to see, so again, it's amber, but it's not massive variability to have it in red. It tells you what time of the day as well. And that makes life much, much easier for both the doctor and the patient. Now, of course, theory is very good. Does this AGP business work? And we have conducted a multi-center study in the UK to try to answer that particular question. We conducted that in both type 1 and type 2 diabetes patients who are on multiple daily injections of insulin. So they went on CGM, and then the AGP was assessed and treatment changes were made according to their AGP profile. It's a 90-day study, so it's a relatively short study, but in terms of CGM studies, it's very long. 29 type 1 and 30 type 2 diabetes patients. The primary endpoint was the time in range between 3.9 and 10 millimole per liter, or 70 to 180 milligram per deciliter. We had a number of secondary endpoints, including HbA1c, time in hypoglycemia, and some other things that I'm not going to bore you with today. The paper, by the way, had just been submitted for publication, so we should hear soon. So what you're seeing has not been published yet. Now, what about the primary endpoint? So I'm presenting the data as a graph, but also present it as tables so you can see the numbers. If you look in the type 1 diabetes patients, there was no increase in time in euglycemia. So you say, this was a bit useless. Well, we will see. In the type 2 diabetes patients, there was an increase in time in euglycemia. So their time in euglycemia increased from 13.3 hours a day to 14.7 hours a day, or 1.4 hour a day increase, which was statistically significant. If you look at HbA1c, HbA1c fell in people with type 1 diabetes from 9 to 8.6%, which showed a trend. Wasn't fully significant, but the p-value was 0.07. And you may say, well, how did it fall if the time spent in euglycemia did not increase? It'll become apparent in a moment. But look at the HbA1c in the type 2 diabetes patients. It had an absolutely major fall from 9.1 to 8.2%, and that's over 3 months only. P-value very significant, 0.0002. Now you're thinking, why did the HbA1c fall in type 1? And I believe it fell because of this. In type 1 diabetes patients, to our surprise, they were spending an average of 1.3 hours per day in hypoglycemia. And that fell to 0.8 hours a day after the intervention. And I think this is why the HbA1c fell, because as you know, after each hypoglycemia, you get a peak in glucose because you overcorrected, and that's why the HbA1c fell in this group. Despite this massive improvement in HbA1c in the type 2, as you can see, there was no increase in hypoglycemia. If anything, they went from 0.6 hours a day to 0.5 hours a day. So it was a decrease in hypoglycemia in this group, which wasn't significant. Let me just finish by giving you a real-life example of how we manage these patients. So this is a male patient. He's 59 years old. He's got type 2 diabetes, 10 years duration, HbA1c 9.3%, so we are not happy with that HbA1c. He's on Novorapid, fixed doses, and Levemir once a day. Also, to make sure that we're trying to reduce his insulin requirements, he's maintained on metformin 500 milligram BD. This was his profile. As you can see, his risk of hypoglycemia is non-existent. He is well above that lower line of hypoglycemia. The middle line, the median goal, most of his readings, well, the median is generally above it, so he's not reaching his median goal. As for variability, he's got moderate variability, pretty severe variability at the later time of the day. So what have we done? Targets we reassessed and discussed, and we said we're going to get his glucose targets to 5 to 9 millimole per liter. We thought the metformin can be increased. So increase the metformin 1 gram to twice daily, and we did an increase in insulin doses across the board. Also, remember this guy was on fixed doses of Novorapid, so we involved a dietitian to tell him or to teach him carbohydrate counting so he can vary the dose of insulin according to the size of the meal. And this is what happened. As you can see, the median glucose fell down quite remarkably. His risk of hypoglycemia is still non-existent, and the variability is getting better. He was on Levemir once a day. We decided to split Levemir to 2 doses, tolerating the high dose metformin very nicely, and he continues to see the dietitian for further education on carb counting, and this was the latest with him. Much improved, no hypoglycemia, more confident about managing his diabetes. His HbA1c fell significantly, and I think you agree with me, I don't have diabetes, and I'd be quite happy to have that kind of profile in my glucose. So who would benefit from AGP? Is everybody for AGP? Is everybody for this new device? Well, in the UK, as you know, healthcare is free, and we can't have everybody on this device. And I think that people who are suitable would be people with difficult glycemic control, people having frequent hypoglycemia, certain professions like lorry drivers, bus drivers. Ideally, all patients given to convenience, but as I said, there is the issue of cost. The cost of the device is far, far lower than current CGM devices. So if you have a patient who is testing 10 times or more, then this becomes either cost neutral or more cost effective. Patients not on insulin, you may want to use it temporarily, people who are having severe hypoglycemia, and again, in certain professions. So to conclude, AGP offers an accurate and convenient description of blood glucose levels, relatively easy to interpret, and offers a more comprehensive glycemic assessment than SMBG. And what I've found is that patients absolutely love it. And I have sort of three types of patients. One group learns everything and they end up changing the insulin themselves. The second group understand what's going on, but they're not brave enough to change their insulin or treatment, and they want to discuss it with a healthcare professional. The third group doesn't want to change anything, can't interpret it, but when you explain to them what's going on, they understand why we changed the therapy, and they are very happy. I'm yet to have a patient who says, I don't want to look at the AGP. That hasn't happened yet. AGP helps to identify periods of hypoglycemia and large glucose variability, which, as I told you earlier, are associated with adverse clinical outcome. And I was shocked to see that people with type 1 diabetes are spending, on average, 1.3 hours a day in hypoglycemia. This new Freestyle Libre device offers the exciting possibility of a more comprehensive assessment of glycemia, so we can incorporate all three arms of that triangle when managing glycemia in patients with diabetes. Thank you very much for your attention.
Thank you very much for your very interesting look at the glucose. We still have many people look at single value and make decisions, but nowadays with the available technology, probably we have to look at our patients in more details. So, any questions? Dr. Zaidan, please. Mike?
Thank you, Doctor, for this very nice topic. I enjoyed it. My question, for this, the Libre device, this is very good because it has no need for calibration and it is every 2 weeks. Are you planning the future to have an insulin pump that transmit these all data to the pump so we'll avoid having two different companies?
First of all, thank you. Thank you for your comment. Very important question you're raising there. And I did ask the company that question, whether they are planning to pair it with a pump, because that would be quite a good idea. And to my knowledge, there are no immediate plans for that. What will happen in the future, I don't know. But as I said, to my knowledge, no immediate plans. But that would be a very good way forward. Absolutely, completely agree with you.
Any more questions? Dr. Hassa?
So trials in children. So the device at the moment is licensed above 18. However, we just completed a pediatric study. And the plan is to move it down to the peds. There's an issue with the children that very young children have got very small arms and you can't put it in the arm. So the idea is whether you can put it here in the back. I have to confess, one of my patients decided that she doesn't want to use the arm and she's using here the back and it's giving perfect readings. So yes, there are plans to move it to the children. What's it? Well, I mean, from my point of view, provided that we tested it in children and it's safe and it should be, there's no reason why it shouldn't be, provided you can put the device on, there is no reason why we can't go down to very young age.
Any more questions? Now, in the workshop, there are going to be more details about the use of the machine, and also if you have more questions about the AGB, probably can express it in the workshop. By the way, the workshop you can attend it. You don't have to re-register for the workshop. It's free, so you can attend the workshop. Before I let you go, we'll give you your... I'm
very humbled. Thank you very much.
Thank you very much.
Thank you very much.
Thank you. Excellent. So, as I said, the workshop, you can have more questions about the same subject. One of the house points before we go for the long break, تسليم الأجوبة عند booth Medtronic, and راح يكون عندنا إن شاء الله بعد ما we go out 12:15 راح نبدي احنا راح نبدي 12:30 and 12:15 راح يكون في سحب ثاني والحين في سحب الحين قبل لا نخليكم to go. So we'll go with the سحب. دكتورة زينب ذبحتنا بهالسحب هذا. يلا اوكي let's get. طبعا اللي ماخذ امس will not give him again. لان هذا محظوظ وايد يعني he can get something else. خالد جلال حلمي. ماجدة فوزي. Okay, so we'll go for the break. Thank you for staying today with us. We have a very interesting program coming, and also راح نواصل في سحب الهدايا. Sorry. So. Yes. راح يكون في سحب ورا الغداء وفي سحب بعد كل وركشوب. رابطينكم عدل. Okay. So we'll start choosing the winner. خلي دكتورة حصة. دكتورة حصة. إيه روحي وديها روحي لها. أوكي أنا ودي. يلا. يلا روحي. علاء ولا علاء؟ دكتور علاء عباس؟ دكتور علاء عباس؟ اوكي. دكتورة أمينة؟ أمينة طه؟ أمينة؟ يلا she won an iPad. Good. Perfect. Okay, next. يلا ناخذ. دكتور خالد أحمد. لا مو موجود. اوكي مو موجود راح نمشي. دكتور سامر وصفي. سامر yes موجود. With our lectures, we have a very special guest today, Dr. Ian Creston. I was lucky to know him. I went last year for a week. We worked with him in Southampton Hospital for 1 week and seeing, learning from his experience and dealing with patients with diabetes. He had a research fellowship at King's College in London, and he's working as a consultant team in Portsmouth. And his interest was in the intensified insulin therapy. He has lots of published paper in this field, and he's also expert in the AGB, the same as the lecture was previously given. So he's going to give us actually the 2 lectures in 1 lecture that was posted to him. So we're going to listen to him and enjoy. I'm sure we're going to enjoy his talk.
So I hope I have a bit better luck with the microphone. Yes, looks like. Thank you very much for inviting me here. It's a great pleasure to be on this wonderful boat. As always, one has disclosures to make at the beginning of any talk. You'll be aware that this talk is a sponsored talk for Eli Lilly. As you'll see, I do take sponsorship from a number of places, given the opportunity. And one of them you'll see down towards the bottom of the slide is this training program around the use of AGP. And certainly over the last 2 or 3 years, really, the use of that technology has almost become a routine part of clinical practice where I practice. And so what I'd like to try and do today with this topic title is to go through a little bit of what we've learned over the last few years about what we're actually trying to do when we treat glucose levels and whether we need to slightly rethink our paradigms around treating glucose levels. And to then think in specific terms around the decision-making processes we make using injectable therapies. And obviously, because this is a sponsored session, I'm going to be thinking about the decision-making processes around dulaglutide, which I understand it has licensing permission here in Kuwait, but is not as yet licensed fully. But also the insulin decision-making processes that we use when we're thinking about using mixed insulins, and in particular the analog mixes, and how we perhaps select patients for those groups. So, of course, it all really boils down to why do we treat glucose levels at all? And I think in my mind anyway, there's 2 really clear elements, which is macrovascular complications, although they are the complications that we recognize are those which are responsible for early mortality, and although they clearly have some relationship to glucose control, are not the primary benefiters when we're treating glucose. It's actually microvascular complications which are the main reason we treat glucose. And so I think that's important to bear in mind. Because when we look at data from studies such as the UK PDS, what we see in the green bars on this slide, on the left-hand side of the slide, is that the benefit shown for treatment of microvascular disease was far greater than the benefit shown for macrovascular disease when we look at glucose control as the primary therapy. And of course, the important part of the UK PDS study was actually, in my mind anyway, is the follow-up data from 10 years after the study finished, which showed that those benefits that accrued over the first 10 years were still accruing 10 years after the study finished, at which time the glucose control between the 2 treatment groups was very equivalent. And it's this legacy effect for the impact of glucose, particularly on microvascular complications, but actually, as you can see on the right side panel, the macrovascular disease risk in brown for MIs, the quantitative reduction is very similar between the 2, but because 10 years down the line, the rate of macrovascular disease is getting higher, actually 10 years after the study ended, the impact of macrovascular disease was very statistically significant as well. So I think those are the why elements of it. And of course, one of the problems that we had with the whys is that our confidence in treating glucose took a bit of a dent when the ACCORD study was published. Now, the ACCORD study, if we remember, only looked at macrovascular disease. It wasn't looking at microvascular disease, and so we would perhaps not expect the impact on its outcome measures to be as dramatic as perhaps something like the UK PDS would have been. However, I think the other element, when we actually look at the glucose data from the 2 groups, and this slide represents all the data from the ACCORD study, there's some interesting facts that come out. If you just focus on the brown data on this slide, the brown data represents the mortality risk over the period of the study for patients in the intensively treated arm. And along the x-axis, we've got the achieved mean hemoglobin A1c during the study. And what we can actually see for the intensively treated group is that glucose control was very clearly associated with adverse outcome death in the case of this data set. However, when we look at the other half of the population being treated, those on more conventional treatment, although we can see that there is clearly also a relationship between glucose control and mortality risk, it's a completely different relationship. And if you put the two groups together as, if you like, the population overall of the study, which of course is what you and I have to treat in our clinics every day, it's the whole population, the line is completely flat. So hemoglobin A1C as a single measure wasn't a very good outcome measure at all from the perspective of this study. And so we started to get confused by it. And of course, there was then lots of delving into the ACCORD data to find out why was that the problem. Lots of negative studies were looked at from that perspective, and the one that kind of brought it to our minds most was this information, the data about hypoglycemia. And what was very clear is that for all achieved levels of hemoglobin A1C, those who were in the intensively treated arm of the ACCORD study had about 3 times the risk of severe hypoglycemia. And that's been put forward, therefore, as a reason between the outcome differences between those two groups. But actually, there's something more important in my mind looking at this study, which is if you compare hypoglycemia risk in the ACCORD study with hypoglycemia risk in its equivalent study in type 1 diabetes, so in this case the DCCT, what we see is that the relationship between severe hypoglycemia